All right, welcome to week 21 of our neuropsychiatry didactic series. This one is going to be on OCD and related disorders. And this one is going to be a pretty well-established one since, kind of like depression, it always feels comfortable when we know the circuitry well enough to do neurosurgery on something. And OCD also exists in the neurology territory as well. So exciting to talk about that. Here are our learning objectives. You can go through that. And we'll start off with a little bit of a timeline to get us going. So the original cases of obsessive fears and ritualistic behaviors that we would now call OCD were initially seen through more of religious and moral lenses, like most things that people could commonly be seen as morally conflicted or sinful. And interestingly, there is still a subtype of OCD that still exists called the scrupulosity subtype, which is defined by obsessions related to religious or moral, of religious or moral nature, and that can cause intrusive thoughts, excessive guilt, and compulsive, reassurance seeking, or even excessive confessions in terms of behaviors. And so it's interesting that historically that still lives to this day. This scrupulosity actually was termed in the 15th century by these Catholic theologians, Saint Antonius of Florence, which we actually see in the picture on the right, and John Gerson. And then by the 19th century, Pierre Genet introduced a concept called psychasthenia, which he described as a weakening of the functioning of reality, which characterized patients that he saw that were suffering from what he perceived as deficits in mental energy, and sort of lacked an integrative capacity, which led to what he described as intrusive thoughts, doubts, and decisions, excessive rumination, and ritualized behaviors. As we'll talk about later, this is surprisingly not that far off from reality in terms of the neuroscience that we know today, and possibly allude to some deficits in frontal striatal inhibition that we'll go on to talk about how that impairs control over mental processes. By Freud's day, he reframed this into a what he called obsessional neurosis, and he described this as a disorder of conflict and defense. In his very famous Rat Man case, he conceptualized compulsions as symbolic acts of aiming to neutralize unconscious impulses, which tend to be aggressive or sexual in nature in his day and were seen as unacceptable. He also introduced a few psychoanalytic concepts related to this as well. So some of these, just to mention three, one is isolation of affect, which is that the thoughts are stripped of their emotional context. There's also undoing, which are rituals that symbolically reverse forbidden wishes. And then reaction formation, which kind of describes an act of exaggerated morality in response to unconscious hostility. So you feel bad and you do about it. You feel some bad thing about somebody and you try to undo it by doing the opposite. Um, and so, that has all those things have sort of an OCD like flavor to them. By the mid 20th century, now that it's kind of like the behaviorist revolution kind of period, this field shifted towards more behaviorist models, especially with this guy Maurer, who made a two-factor theory, which basically described that obsessions arise from classical conditioning, which was termed fear acquisition, and the compulsions persist via operant conditioning, which was termed anxiety reduction. And so this framework directly led to exposure and response prevention therapy, also known as ERP therapy, which is actually still the gold standard of psychotherapy for OCD. And now that we have functional neuroimaging, there's been plenty of new modern research that further elucidates the mechanism of OCD, and with some showing how psychotherapy can alter brain function and reframe and it reframes OCD as a reversible circuit disorder, which can even, be, like I said, tangible enough that we can actually target it with neurosurgery, with neuromodulation. And so to sum up, it's interesting how none of these reconceptualizations of OCD has really, dismissed each other. Because, psychoanalysis still explains why some themes tend to dominate to this day. Behaviorism explains how the symptoms can persist. And neuroscience, still, of course, explains where the mechanism is. Um, and from cultural perspectives, ritual is a very normal human function across cultures and serves many functions, such as maintaining social order, reinforcing group identity, regulating anxiety and uncertainty, and transitioning through developmental milestones. There's an anthropologist who studied rituals named Victor Turner, who described them as guiding individuals through periods of ambiguity and transformation, which he called liminal states. And so OCD can be understood as a failed liminal process, where the patient is basically stuck between danger and safety. And these compulsions are used as repeated attempts to cross this threshold. Rituals can also become pathological if they occur outside of their cultural context. And so once these rituals lose their symbolic meaning and their flexibility and their social containment, then it becomes pathological. And although OCD, happens, of course, all over the world, the way it expresses varies by culture. And so somatic obsessions, for example, th those tend to be more common where psychological language is less emphasized. In East Asian cultures, obsessions often focus on themes of social harm and offending others rather than contamination. And then in some collective societies, compulsions may center around maintaining harmony rather than personal safety. And in these examples, the underlying circuit dysfunction may be, universal, but the narratives that they're attached to are cultural. And we're also going to talk about how different circuits can also manifest with different obsessions and compulsions too. Okay, so before we go into talking about the OCD family and DSM-5, it's also important to note how relatively new it is. The DSM-5 is actually the first iteration of the DSM that lists OCD and related conditions as their own disorders, and rather than being viewed as a subset of anxiety disorders. And now OCD, is described by their own common features as having a compulsive element, habit formation, and loss of inhibitory control, with anxiety being secondary rather than primary. Um, and it's really interesting how psychiatry, is still feels like a new field, and we don't have to go that far back in time before we didn't really know much of any of these disorders. And obsessive compulsive to COCD, as described by their anxiety, its anxiety is really just focusing on the anxiety related to the OCD rather than the circuitry or having a better, more evolved understanding of the circuitry of the OCD itself and the biology involved. And now that this is more fleshed out, we also see a lot of overlap between OCD and tic disorders and Tourette's that we see in neurology, along with impulse control disorders as well. And these are, way different than the more anxiety driven stuff from previous DSMs, like, or fear-based phobias and things like that. And so this wasn't always common sense, but, this obviously was fleshed out through a lot of neuroimaging studies that we'll talk about. But and so the DSM-5 really focuses on the compulsivity and repetitive behaviors of OCD, which is a distinguishing factor from anxiety. And so here's all the DSM has to say about OCD minus a whole bunch of other texts, but this is the main criteria at least for OCD related disorders. Sorry, it's a lot, but you can pause and review this in your own time. And so upset. So, we will focus more on OCD with its criteria being obsessions, compulsions, or both, which I think is kind of weird because, it's obsessive compulsive disorder, not obsessive or compulsive disorder. But obsessions are defined as recurrent, persistent thoughts, urges, or images. They're experienced as intrusive and unwanted and cause, a lot of anxiety and distress. And it's important to know that these obsessions are what's considered ego dystonic, meaning they're distressing to the self, opposed to OCPD, which is ego syntonic. And those obsessions are actually typically useful and possibly even adaptive to the self. Um, Compulsions, as we see here, is defined by repetitive behaviors like, washing, checking, or ordering, or repetitive mental acts like counting, praying, or undoing. And these are performed in response to an obsession of some sort, or according to rigid, self-imposed rules. And whether these presentations include obsession, compulsion, or both, the criteria B in these disorder here requires that whatever it is, it's time consuming. So over an hour of the day, which is quite a lot, or cause clinically significant distress or functional impairment. Um, like most disorders in the OCD. And we can also specify the OCD by the patient's level of insight, which is important not just to give us to give us an idea of how treatable something is. The better the insight, the better predicted treatment response will be. Um, and also to give us an idea qualitatively, this is kind of a little bit of an off tangent, but there's a comorbidity between OCD and psychosis, and people with basically the less insight people have into their OCD, the more closer to the psychotic spectrum of things that it's thought to happen occur. And at the bottom here we even see that, but even lower than poor insight, there's absent insight with delusional beliefs. Which is interesting that it shares similar delusional circuitry that we sort of talked about from a predictive coding standpoint in our psychosis lecture. Um, and of course, anything in the DSM, there's always going to be a disorder that's either secondary to a medical condition or it's substance or medication induced. Um, and so some medical conditions that can lead to OCD-like behaviors are predominantly in the basal ganglia. Those could be strokes or tumors affecting like the caudate region, for example. Anything that messes with dopamine can cause this. So sometimes we see this with the use of dopamine agonists in Parkinson's disease or stimulants. There's something called like punding behaviors or impulse control disorders that kind of share some overlying common circuitry. Some autoimmune conditions like PANDAS or autoimmune encephalitis can have OCD-like behaviors. And so if you ever see, new OCD symptoms in a relatively older patient, then, this should definitely prompt a neurologic evaluation. And so some other disorders that live in the OCD family here is hoarding disorder up top. This is defined by persistent difficulty in discarding possessions, regardless of their value. And then we have picking disorder, including trichotillomania, which is hair pulling, and this recurrent hair pulling usually has a premonitory tension or urge and relief by doing the actual behavior of pulling. And excoriation disorder also has this urge, but it's skin picking instead of hair pulling. And so there's a lot more within this, but these are the most common ones. And so to talk about their functional neuroanatomy. So the most important circuit to know for OCD are actually the many corticostriatal thalamocortical loops, which from now on I'll just be calling CSTC loops. But of course, there's a whole lot of different loops that we're going to talk about. But the common thing, hence the name, is that they're cortical, meaning, it can include the orbital frontal cortex, anterior cingulate, or prefrontal regions. And then there's striatal, which means, involving the caudate and the putamen. And then their thalamo for the thalamus, and then going back to the cortex again. And so these CSTC loops are evolutionarily conserved circuits. They link thoughts, affect, and action, and they allow the brain to initiate behaviors and monitor their correctness in this closed feedback loop, and then hopefully also terminate whatever it is that they're doing once whatever the goal is unleashed. And so, as we can imagine, in OCD, it's really the termination that's not working. And so, basically, I guess to just to do some background here, there's a lot of functional imaging studies in OCD that shows a hyperactive obsessive sorry, a hyperactive orbital frontal cortex and caudate, along with anterior cingulate cortex too. And it's just thought that, these areas, of course, aren't working as well. As we know, the anterior cingulate cortex is really good at trying to detect an error signal. And if it doesn't, then the error signal is going to be bypassed, and you can risk kind of being stuck in a loop. Um, and anything cortical really is supposed to generate some kind of understanding of any kind of signal that we're getting from lower brain states. And so, it should answer the question of like, is something wrong here? Which, usually the ACC does a good job at. And is there a way to regulate this or to kind of change this, which is usually done at the level of the OFC, and what kind of action is needed, which is something that the dorsolateral prefrontal cortex and sometimes the ventromedial can take care of. But at some point, some part of the cortex isn't really stopping these aberrant signals. And there's also, signals from the striatum to the back to the cortex have to be fed through the thalamus. And so the thalamus usually plays or should play a gating function of some sort. And so this could also happen. These error signals can be bypassed if the thalamus isn't doing its gating function correctly. So, in these CSTC loops, a breakdown at any point of the loop can cause an aberrant signal to be kind of stuck. And if it can't be stopped, then it just keeps going. And so that's kind of that ongoing loop is thought to play a pathologically self-reinforcing behavior and cycle between obsessions and compulsions. And so, going one by one here, this self-reinforcing aspect of OCD can actually happen at many levels, starting, with the cortex, like let's say, or the orbital frontal cortex. It should generate an error or threat signal, but the caudate nucleus, in the striatum, might fail to adequately filter or inhibit these signals. Then the thalamus is going to continually re-amplify these signals back to the cortex, and then the cortex kind of sees this as sort of unfinished business, and so it fails to shut it off. And so if we were to zoom in the basal ganglia, there's two overall basic pathways that get affected in the basal ganglia. We have a direct pathway and an indirect pathway. The direct pathway allows for for enabling of movements, and the indirect pathway allows for the stopping of movements. And in these OCD type behaviors, it's been thought that the direct pathway becomes relatively overactive and the indirect pathway becomes relatively underactive. And so that off balance actually facilitates movement and improper gating. And so this kind of leads to, something that's kind of similar to the motor perseveration that we see in other basal ganglia disorders. And while all of this is happening, like we mentioned, the anterior cingulate cortex isn't really picking up on this error, and it's not really picking up on monitoring this conflict of signal. And so basically, in functioning imaging studies, interestingly, the anterior cingulate cortex is actually seen as always on, but it's actually paradoxically not really doing its job really well while these signals get passed. And so, and like I've mentioned, I think before, the anterior cingulate cortex really holds the emotional content of the brain. And so what's interesting for this one is that, this sense, this OCD type sense that maybe something is wrong, is thought to also likely originate from the anterior cingulate cortex, sort of in some level recognizing that there's faulty signal, but not really doing anything to stop it because either the signal is too intense or it's somehow it has been inhibited in its ability to. And so, when we think of OCD, it's interesting that there's so many different obsessions and compulsions, and there's varied presentations. And so, one idea as to why that's the case is that there's actually multiple different parallel loops that are functionally specialized. And if one loop is affected, then it kind of governs the phenotype of the OCD. And so, just to talk about some of these kind of broad loops. First, we have this affective or limbic loop. This is composed of the orbitofrontal cortex and the ventral striatum. It's thought to govern emotional evaluation, disgust, and moral threat. And this may actually underlie that scrupulosity subtype that we saw in our history slide, along with some contamination subtypes of OCD when this loop is dysregulated. Then we have a cognitive or associative loop, and this involves the dorsolateral prefrontal cortex and the dorsal caudate. This helps coordinate, if there's any doubt or checking behaviors or decision making. And this if this is pathologically dysregulated, then it could lead to some checking rituals, which is a very common type of OCD. And then finally, there's a motor loop. This is made of the supplementary motor area and the putamen. It's involved in habit formation and sequencing of actions. And when this is aberrant, this may lead to tics, ordering, or symmetry compulsions. And of course, experiencing any of these phenotypes of OCD can feel pretty distressing, and it's eventually pathologically learned and it can commonly lead to a lot of anxiety that's also habituated over time. Some clinical mechanisms, since OCD is a pretty heterogeneous condition with so many different phenotypes, understanding the phenotype can actually, might predict its specific mechanism. It could actually allude to some neuromodulation targets and even predict some treatment response. So patients that predominantly present with contamination and cleaning themes, these are like, obsessions related to fear of germs and bodily fluids, pollution, etc. And they might have compulsions to excessively clean or wash or avoid things altogether. And disgust tends to be more common than fear for these patients. So the neural correlate of that is thought to involve a hyperactive insula along with the orbital frontal cortex. And so these patients are thought to benefit from SSRIs and ERP therapy, and their insight tends to be pretty preserved. And so tends to be a little more, treatable. Now, for the next one, patients that have a phenotype of checking behaviors and harm avoidance, who tend to have, checking behaviors include like, repeatedly checking if they locked the door, if they turned off the stove, or anything related to safety, and they're unable to tolerate uncertainty. Some of the underlying neurocircuitry here is thought to involve a hyperactive anterior cingulate cortex, and a dysfunctional connection with it and the dorsolateral prefrontal cortex with the dorsal caudate. And so patients here tend to be more distressed. They have strong responses to ERP that targets more the tolerance of uncertainty. Um, and if their doubt becomes rigid, then antipsychotic or augmenting with antipsychotics can actually be helpful for these patients. And then let's see here. Well, another dimension here are people who have OCD that's characterized by things not being like not just right, like people who are really obsessed with symmetry and order and just feel like things are off all the time. So these people really need to be very exact and balanced and complete, and they may have compulsive behaviors like repetitively arranging things and touching things and counting things. And the circuitry underlying this, might involve the supplementary motor area along with some of the sensory motor CSTC loops as well. And so clinically, this may be more likely to overlap with tic disorders, and may respond to tic therapies like habit reversal therapy, but it may not be as responsive to SSRIs alone. Um, Hoarding behaviors are another dimension. This may involve underactivation of the ventromedial prefrontal cortex and the insula. And these patients tend to have poorer insight and maybe less responsive to SSRIs. They may require a specialized CBT, which focuses on the decision making and emotional attachment. And one that I didn't list here are people who have OCD that their OCD revolves around taboo thoughts. This might be related to sex or aggression or religion, and these tend to be intrusive, very ego dystonic, with severe feelings of guilt and shame. And this is thought to involve more so the orbital frontal cortex, which is involved in like the valuation of morality, along with the anterior cingulate cortex and default mode network. And this actually might be sometimes misdiagnosed as psychosis, even though, interestingly, these people tend to have typically good insight. And that's actually the good insight is the reason why they feel so much distress. And so these patients are more internally impaired, and they might not actually have as much observable behavior, and a lot of these things are more in their minds. And of course, in any of these phenotypes can be mixed in some way and vary in levels of severity and treatment response. And so while OCD is a circuit disorder, the balance of neurotransmitters are always going to be important in circuit disorders and might determine how rigid or modifiable those circuits are. So to talk about serotonin, like we discussed, SSRIs are the first line treatment for OCD, but higher doses are really commonly needed more so than in depression. And the thought here is that those that 5-HT2A receptor activity really needs higher levels of stimulation to shift these networks towards a state of greater flexibility. And so that flexibility is really needed to treat this condition and provide more top-down inhibitory control from the cortex, and dampen that excessive error threat signaling from the OFC, along with the caudate nucleus is likely hyperactive and it needs to be calmed down too. And so the higher level of SSRIs are thought to lead to improved insight and cognitive flexibility over time. And so that's why that's the you need to target the root cause of the anxiety um, rather than its own disease. Like so. Of course, SSRIs help with anxiety, but it's probably not going to help with OCD related anxiety without targeting the actual OCD at a higher level. And so dopamine is involved in regulating striatal gating. And it tends to be most effective when the compulsions are prominent or insight is poor, especially when psychosis is present. And these are often in SSRI refractory OCD cases. And so on the opposite end, we actually, interestingly, also see compulsive disorders worsen in Parkinson's patients who may be on too much dopaminergic medications. And so it can kind of work in both ways. And for glutamate, the glutamate's been more recently implicated in OCD with the thought that, and this was really because, it's thought to there's some preliminary data that certain glutamate modulators like memantine, ketamine, and riluzole might actually show some promise in specific types of OCD. And the thought here is that excessive excitatory transmission might actually drive CSTC loops and lead to perseveration. And so I know this is quite a lot, and it kind of seems like it's all over the place, but just to summarize here, just at least these three chemicals. So serotonin is thought to modulate flexibility of cortical control. Dopamine determines striatal gating and the persistence of habits. And glutamate provides the excitatory drive that would sustain CSDC loops. And so OCD might emerge when, just about any of these neurotransmitters are imbalanced. But it's important to know that, the management of these circuits aren't really driven by any specific neurotransmitter. But, the treatment goal is really to restore balance, if anything. And psychotherapy like CBT, has actually shown to similar changes to these circuits as even like SSRIs has shown. So targeting these circuits from multiple angles seems to make the most sense. All right, so clinical relevance here. So in terms starting with the workup, of course, we always start with history. The history is going to be, really related to that DSM-5 criteria that we talked about. And so, here we're going to ask questions about the nature of the obsessions, the nature of the compulsions. Are they ego-syntonic or are they ego-dystonic? Is it gradual? Did it happen all of a sudden? Are there any other comorbid conditions that might precede it developmentally? And how old is this patient? Sometimes we see OCD behaviors very commonly in patients with autism. If it's something that happened, uh, you know, uh, since they're very young, then we can think of that or pandas. And if it's something that happened, very acutely at older age, then we might think of a more neurologic etiology. Um, and then from a psychiatric standpoint too, a lot of psych diagnoses can mimic OCD. And so psychotic disorders can have delusional beliefs that people can be pretty persistent about, and it may seem obsessive. Major depressive disorder, is characterized by ruminations, and this may also, seem obsessive, but usually mood congruent and passive. Generalized anxiety disorder can have worries that can be realistic sometimes and future oriented, but also have the perseverative quality. People with autism can have repetitive like stimming behaviors, and they can also have stereotypies, but these aren't associated with the stress. Typically, they're usually more for self-soothing, so not OCD. And then, of course, as we mentioned before, OCPD, obsessive compulsive personality disorder, is egocentric. So, they lack these disturbing, intrusive thoughts. And so remember that, OCD symptoms can come from the basal ganglia, can come from the frontal lobe, or they can be limbic. So those CSTC loops are, hit a lot of surface area. And so technically, you could have sort of like a stroke or a lesion of some kind that can actually cause new OCD symptoms. And so some kind of neurologic red flags listed here are if the symptoms are late onset, if they're rapidly progressing, if there's an associated focal deficit or movement abnormality, if there's cognitive decline or a fluctuating mental status, or have seizures or autonomic instability. If any of these red flags are present, this would sway you more to a neurological workup, which of course would include a head CT, MRI, and possible EEG and LP. Even saying this, I had a really interesting case of a 33-year-old guy at the time with new onset obsessive thoughts about like the world ending and that he needs to like do something about it, but he was kind of stuck on what to do, and he just had these thoughts over and over again. And then, we just thought that this was just like a classic OCD case, and we ended up scanning his head. And even though he was in his early 30s, his frontal lobe was like shrunk, and I'm not. He was too young for it to be FTD. We're not really sure what happened here, but it's reasonable to think that a hypofrontality could affect the function of the orbital frontal cortex and disrupt CSDC loops, and that in itself can cause an OCD phenotype. And so, if somebody has OCD, you can track them with several different rating scales. One is called the most common is the Y box, which is the Yale Brown Obsessive Compulsive scale, and that's been kind of the gold standard there. And then, as usual, we can do basic labs, like metabolic studies, especially if there's a movement, new movement issues that are suspected, an infectious workup if there's systemic signs. Like, there is this idea of pandas causing this too, and also autoimmune panels if it's abrupt too, especially in pediatric causes. All right, so really briefly, even though we don't really do neuropsychological testing in OCD, it's worth talking about just because there's some interesting things. Like, interestingly, people with OCD tend to actually have average or above average intelligence. They actually have intact memory. So this is different than, just about most of the things that we talked about so far, like depression, anxiety, and psychosis. And they have usually like a very selective dysfunction in their executive control. And so it's not really, all of their executive function that could be messed up. Actually most of it is normal. Their issue is mostly on their cognitive rigidity. So their ability to set shift, to be flexible, to tolerate uncertainty. That's really and their intolerance of ambiguity. That's really the issues that they tend to have neuropsychologically. And so one of the core neuropsychological signatures in OCD is having excessive error monitoring. And interestingly, this is also shown on EEG with this thing that I just learned recently called ERN or ERN, which is an exaggerated error-related negativity, which is a sign that we actually see on EEG. I should have put a picture here, but it also may be seen with heightened responsive. It's also seen with heightened responses to perceived mistakes. Um, and so it's interesting that we actually get, a certain a kind of biomarker of this phenomenon of cognitive rigidity and OCD. Um, and even though interesting, like it's very common that patients with OCD, despite having intact memory and normal to above average intelligence, like we said, they might still often complain about subjectively bad memory. And we're not really sure what this really means. It almost seems like it's not really a problem in the memory itself, but rather their confidence in their memory, or they could be, it could be another thing that they're obsessed with as well. All right. So here's we're going to talk about functional imaging studies. So we're going to discuss actually more of this in the next slide. But starting since like the 80s or 90s, we found a lot of associations in the brains of people with OCD. One of the first was Baxter in like 92, who showed that there were functional changes in people with OCD that we'll talk about. And some of the most common changes is hypermetabolism of the orbital frontal cortex, the anterior cingulate cortex, the caudate nucleus, and the thalamus. And so some potential explanations here is that starting from the top, hyperactive orbital frontal cortex might start tagging what was previously neutral stimuli as now potentially wrong or dangerous. The anterior cingulate cortex being exaggerated might, explain a subjective sense of unease and this exaggerated error-related negativity. A hyperactive caudate may allude to some aberrant gating, leading to some of those intrusive thoughts being allowed to enter consciousness. And then the thalamus can also, have aberrant gating in itself, but also amplify this already excessive these already excessive cortical signals. Um, and so there's some even newer data that are fMRI studies that show an increased functional connectivity within these CSTC loops, and that's probably because of their self-reinforcing ways. And there's, of course, always the salience network has to be involved in some way, and there's abnormal coupling between the salience network and the default mode network. So here's the landmark studies that I promised, and I think that they will help us have a better view of OCD through time. Um, so like I said, Baxter et al. Sorry, I think I actually misquoted the year, but in 1987, it showed hypermetabolism in the orbital frontal cortex, caudate nucleus, and thalamus in patients with OCD. And then in 92, he went on to show that, interestingly, that medications and psychotherapies both reduced this hypermetabolism to similar degrees. So whether it was like high dose SSRIs or if it was like therapies like CBT and ERP, they actually both reduced this brain function in a positive way. And so it was interesting that this effectively moved OCD from being some kind of neurotic disorder of some kind to a real neuropsychiatric circuit disorder with treatment implications and measurable brain change. And in the second bullet point here, Scott Rauch in 94, he showed that based on the Y-box score, so the symptom severity of OCD, you can actually see a associated the similar degree of orbital frontal and caudate activation. So he's basically showing that not only is the orbital frontal cortex and the caudate nucleus hyperactive, depending basically a higher Y-box score would be correlated with a more active, a proportionally active OFC and caudate. Um, and so the picture that we see here actually on the slide is from that PET study measuring the intensity of how much the caudate and the OFC light up. And so this kind of helped us establish a dose-response relationship between circuit dysfunction and clinical severity. And then by 2006, Christopher Pettinger proposed that OCD also involves glutamatergic dysregulation within these dysfunctional CSTC circuits. And this helped shift OCD away from just being another monoamine model to more of a network excitability model. And then by 2010, there's what's his name? Wayne Goodman in 2010 actually showed efficacy of using DBS that targeted the ventral capsule and the ventral striatum in severe treatment refractory OCD cases, which kind of concretely showed that OCD is not just about the content of the thoughts, but rather this inability of circuits to physically disengage. And then finally, Helen Mayberg is very busy, and not only did she reconceptualize depression for us, but she also worked with Carrie Resler, and immensely, reconceptualized OCD as a network level disorder by, basically doing a lot of work to show how this can tangibly be changed through interventional means. And so, as always, we're going to talk about meds here. And so, but we're going to keep it brief and you can review this in your own time as you like. The first line, of course, like we mentioned a lot, is our SSRIs. So, some of the FDA approved SSRIs here are fluoxetine or Prozac, sertraline or Zoloft, fluvoxamine, and paroxetine. And so, but then, sometimes people can use Lexapro off-label just because it's so common and it lacks side effects. But there's not as much data to prove it. And like I said before, the doses for these SSRIs are pushed further than they typically are for depression and anxiety to target OCD. And also, one thing that we didn't mention is that an adequate trial of any of these SSRIs at a at a high dose actually is about twice as long as it is for mood disorders. So it takes longer for it to work too. And if this doesn't work, then you can start using augmenting agents, like antipsychotics, like risperidone or Abilify. Second line agents here would be TCAs like clomipramine, which is actually one of the most effective medications for OCD. We just don't use it as much because, of course, it's a tricyclic, so there's cholinergic and cardiotoxic effects. And then in real, refractory cases, now off-label, we can use glutamate modulators like memantine, riluzole, or even ketamine, which I haven't seen yet, but apparently there's a little bit of data about that. And then very, very rarely and very judiciously, we could use benzos. I don't really recommend it. It's just here just because, it's been done before, but it's also been shown to impair learning and it doesn't really facilitate therapy. So I would avoid it. And then some other, another off-label option that I don't have any experience with either is topiramate, which is kind of interesting. And I'm not really sure how that works. And so and a rational way to kind of use this is to start an SSRI and then start them on ERP at the same time. And then if needed, you can either switch the SSRI to clomipramine or you can add it, or you can augment the SSRI with an antipsychotic, especially if there's rigidity or tics as well. And then if they're still refractory, then you can add a glutamate modulator. And then if it's still not working and it's still distressing, and then you can consider neuromodulation, especially if the patient is amenable to it. And so this sequence kind of mirrors, the fact that these circuit disorders are usually proportional, as proposed by Rauch in '94 here with his symptom severity study. Um, and so let's talk a little bit more about neuromodulation. So, this shows this is probably the most, physical proof that this hypothesis that OCD is a circuit level disorder really has some weight to it. And especially since we're targeting DCSTC loops and their nodes directly. And it's also like one of the few psychiatric disorders that have an FDA approved neurosurgical intervention. And it's basically analogous to the use of DBS in Parkinson's disease. It's indicated for severe, chronic, and treatment-resistant OCD, which is typically defined as lasting for over 5 years, having shown failure of multiple SSRIs, including clomipramine and even augmentation with antipsychotics, along with adequate ERP trials, and still having functional impairment, like we discussed. So some of the targets that have been shown to help some people include what's most common is up top here, the ventral capsule and the ventral striatum. And then we have the nucleus accumbens, and then we have the subthalamic nucleus as well. And so these nodes serve as sort of converging points for effective cognitive and motor loops. And so, I guess we're not really, always picking the specific loop that we think it is because of the phenotype, just because we don't have much data in doing that. But, theoretically, that would be cool. But really, we're trying to pick parts of the brain that these CSTC loops are just thought to more commonly diverge at or converge at. And so this is thought to sort of disrupt that pathological synchrony. It's thought to normalize the oscillations of these networks and restore flexibility between cortical and subcortical regions. And so data that we have, shows that about 60% of patients actually achieve significant symptom reduction, and improvement, often unfolds over the course of months. And the best outcomes are when DBS is actually combined with ERP after implementation. So it's sort of a DBS, assisted psychotherapy in a way. Um, and these are extremely treatment refractory cases. 60% is pretty impressive, in my opinion. And there are things that are even more dramatic, like you can have ablative options, which could include an anterior cingulotomy, which I've definitely never seen before, but it's an option. And there's also a capsulotomy in extreme cases. And these would, of course, permanently disrupt the connectivity between these CSTC loops. Some emerging treatments that are kind of interesting is closed loop DBS, which is a type of adaptive neuromodulation that we see here on the right. And you can also have like implanted sensors that will detect whenever there's a pathological neurosignature of some kind, um, like hyperactive anterior cingulate cortex or something like that. Then it would cause trigger a stimulation. And then there's less intrusive options like TMS, RTMS. This would be a low frequency stimulation on the nodes that are thought to be hyperactive. A common target here includes the supplementary motor area, or SMA. This is usually used for specific phenotypes, like when people are presenting with issues with symmetry, ordering, or motor compulsion. Another target is the dorsolateral PFC, and this is used for more cognitive control and executive modulation. And finally, the orbitofrontal cortex can also be targeted, but it's less common. But this is thought to be used more for threat evaluation. But for whatever reason, patients don't tolerate it as well, so it's not used as much. And so, to summarize all this, because I know it's definitely been a lot, but if you were to take anything from this at all, is just the idea that OCD is definitely neuropsychiatric. And so, you can see this at all levels. Phenomenology, the neuroanatomy, the neurochemistry, psychotherapy, and how neuromodulations all converge on these CSTC loops. And we discussed how different phenomenologies of OCD can allude to their underlying circuits that might not be working right. Neurochemistry here is really important, and therapy should be in rebalancing these neurotransmitters with medication treatment. But also psychotherapies are very effective here, especially ERP, and they actually, help in the same, just as about the same as much as medications do by affecting these common circuits. That's It can even be targeted neurosurgically through neuromodulations, and can even be used even after the neurosurgeries, like ERP with DBS, and they can complement each other better together than separately. And I will end there. These are my references. And as always, I also have some questions here at the end, just for your leisure. Thanks very much. Have a good day.